All right, you guys, Day My Max 6 back in Santa Monica with the doc. Doc, Ask the Doc is back on the channel. It's
Glad
that
to be
time.
back,
Yes.
right? Yeah.
You get some good questions this month.
Yep. I got, looks like the first one is about HCG. Says, hi guys, I know that HCG is used for PCT, but also used to keep testicles from shrinking while on a cycle and to keep fertile. If I go on TRT and don't use HCG, is there anything wrong with that because I don't care about having kids or my testicles shrinking? No, there's nothing wrong with that. And you're right. Normally, HCG is used post-cycle because guys are trying to get their testicles to start again. And the issue is not so much getting a signal to the testicles, but in other words, luteinizing hormone from the pituitary, but the testicles getting up and running again. And they're a little more sluggish in their reaction. So if you can, as you come off of a cycle or TRT for whatever reason, begin getting those testicles up and running again. I think we've talked about this maybe before. I usually refer to the testicles as diesel engines. Mm-hmm. A lot easier to keep going than to try and restart, but the pituitary is more like a gas engine in that, as soon as you turn the key, it's ready to go. So as soon as the testosterone levels are noted by the body as low, the pituitary will send a signal, luteinizing hormone, to get them going again, the Leydig cells particularly. But it takes a while for that production to return. So again, if you already have the Leydig cells functioning the way they should, and I should add here that HCG looks like luteinizing hormone to the body, so it's a way of beating the system, so to speak. Then when your body recognizes there's not enough testosterone, it will react fairly quickly, much more so than if you didn't do it that way. And yeah, it's used to prevent testicular atrophy, because if you don't use them, you lose them, so to speak. You won't lose all of your Leydig cells. We call them they're senescent for a while. They're senescing. They're sleeping. But with that, they'll shrink. So and that's one of the side effects of TRT or an anabolic cycle, and it can be uncomfortable if when they shrink, the testicles start to rise up, and that can interfere, quite frankly, with intercourse or you name it. There's plenty of reasons for one, your testicles where they're normally supposed to be as an adult, but there are some that don't care. You don't sit on them as easily and don't get them caught between your legs while you're doing squats, is the joke I make with some patients. So it's not mandatory that you be on HCG just because you're on TRT or an anabolic cycle. And ditto for fertility. As this gentleman says, he doesn't care about having kids, so it's a way to keep fertility going. And at this point, I should, like I do with most patients, add quickly that just because you're on an anabolic steroid or taking testosterone does not make you infertile. So don't count on it as a contraceptive. But oftentimes it can reduce fertility or eliminate it depending upon your age, how long you're on therapy, and the way you chose your parents. So there's factors involved with that. And the best way to test for it is literally to test for it with a semen analysis. But HCG can help the Leydig cells function, and the Sertoli cells are the ones in the testicles that make sperm. In order for those to work, you have to have some we call intertesticular testosterone, 3 times real fast. And it's just a small amount, but it's what I call a local prime for the Sertoli cells to do their job to make sperm. So oftentimes, and this is going even further afield here, people will look into infertility and say, oh, well, I need HMG and HCG, because the HMG promotes the Sertoli cells to work. HCG, because it mimics LH, and I should have said the HMG mimics FSH, follicle stimulating hormone. Again, you do your math, and there's nothing wrong with these assumptions, but it's just ignorant of the fact that all we really need in these circumstances typically is not to spend a bunch of money on HMG, but just to get those Leydig cells of the testicles working, and that local prime of testosterone will get the Sertoli cells working. Hope that wasn't too Byzantine.
Would it be okay for someone to be on TRT and HCG at the same time?
Actually, you beat me to the punch. Yeah, okay. I'm going to suggest, based on information that I've gleaned lately, and actually I knew about it before. We just don't have a whole lot of research behind it when it comes to nerve regeneration. And I recently spoke with a colleague, and I hope soon to become a better friend. That sounds like he's a horrible friend, but no, we haven't known each other long enough to be good friends. Is what I mean. But Dr. Eugene Shippen, who's been doing TRT and a lot of other things for a long time, he and I were talking about this recently. The studies from, don't remember where they originated off the top of my head, but in 1983, they were using HCG to help regenerate nerve tissue. And in animal studies, there was a very impressive study where they transected the spine in, it was either mice or rats, I don't recall. And with high doses of HCG, those receiving those dosages, and it was placebo controlled is my point, were able to regain mobility and bladder function, things that we can use to determine how well the nerve has been regenerated. Very impressive. And then there was anecdotally some mention, I believe it was still in the 83 study, and one of the first to bring it to the fore was Jonathan Wright out of the Tacoma Clinic. There were some men who used high-dose HCG, and high-dose meaning like 20,000 IU the first dose, and then 10,000 IU every day for a week, and then 10,000 IU every other day for a successive 5 weeks.
Wow.
Anyway, they had nerve regeneration. The problem was it wasn't a well-designed study. It's completely anecdotal, but it's based upon the animal studies, and the follow-up was not good, and et cetera, et cetera. But since then, since 1983, a long time, we've had other animal studies that bring this to the fore, the nerve regeneration potential of HCG. And it makes a lot of sense if you think about it, because first of all, when is HCG produced most by a female anyway? When she's pregnant, when she's carrying the fetus, and the fetus is building those nerves, right, from a single cell to finally a fetus. And there are receptors. As a matter of fact, they were renamed. Well, let me back up a second. We're using HCG in this particular case to mimic luteinizing hormone, right? We mentioned that earlier. The HCG molecule is unique in that it has an alpha and a beta ligand, okay, component, we'll call it. And the alpha is the same across the board for luteinizing hormone, follicle stimulating hormone, and thyroid stimulating hormone. But the beta unit is what makes HCG different. But we have receptors not just in the Leydig cells for luteinizing hormone, we have them in the brain too, and other nervous tissues. So the theory is that the alpha unit of the HCG acts to stimulate nerve regeneration in nerve tissue. They renamed, like I said, the receptors. It's LHCG, I believe that's what they call it, because they're so similar. They're actually, people call them, HCG is an analog of LH. Actually, more technically, it's a homolog of LH because they're that close. Anyway, I know we're far off of the question, sorry. I'm going to recommend henceforward that patients consider, while they're on TRT, to your question, using HCG concurrently, because when you're not producing your own, or when your body recognizes that there's plenty of testosterone, it's not sending a signal,
right,
LH, luteinizing hormone, to the testicles. And by the way, that signal goes everywhere, not just the testicles. So I think just for, we'll call it health span, general good health reasons, it might be a good idea, and it needs to be borne out with studies. But the good news is it's not harmful, first do no harm, to use HCG. And there are other reasons for doing it, fertility and preventing testicular atrophy. It is a pain in the butt to use. I mean, there's no doubt. You got to mix the stuff, you got to refrigerate it, you got to inject yourself at least a couple times a week. It's all relative, right? But no, I think it's important to know that
there could be some good benefits from it.
Yeah, and the one I didn't mention too, we found out that in some cases when someone gets on TRT and their chief complaints prior to getting on therapy have included decreased libido, and sometimes, well, they kind of go hand in hand sometimes, If you don't have a libido, it's hard to get an erection. And by using, even after testosterone assays have come back up to clinically viable levels, the libido's still not there. We add HCG to the program and bingo, everything works great. It's rare, but it does occur, and we can't explain that all. We can theorize all day long. Might have something to do with that alpha unit. Might have something to do with the fact that the testicles themselves will produce some estrogen. And maybe we go back and we look at, maybe we're oversuppressing estrogen, and that's the key. We don't know yet. We don't have any studies proving that out. It's all theory right now. But just one more reason why you might take HCG, even if you're not interested in the other reasons, while you're on TRT. But at the same time, it is okay to not use HCG on TRT. We've proven that.
Yeah.
I just think at present, if you're asking me which way I would lean on using HCG for the reasons I just mentioned.
No, it's a good test. It'd be a good test to do.
Yeah.
All right. Thanks, Doc. All right, Doc. What else we got?
Next one says, I have watched you for a long time because my boyfriend has watched all of your videos and he wants me to start taking testosterone.
Yes.
I know you say that testosterone is for women as well as men, but I am nervous to try any because of what I see and hear at the gym. I see so many women who look less feminine. They look a lot like guys and have side effects like acne and facial hair. I am 43 years old and have always been in shape by working out and diet, but now I have all the symptoms of low testosterone like no sex drive, fat I never used to have, and no interest in going out at night and being tired all the time. My doctor says my testosterone levels are normal for my age. My total is 12 nanograms per deciliter, I'm assuming, and my free is 0.6. But I have heard you say that normal is not necessarily good. I want to feel better, but don't want to look like a guy or have any of those side effects. What should I do? I want to look and feel better, but don't want to be masculine. Rosa G. Well, Rosa, that one's an easy one. Yeah, a lot of times, very often the poison's in the dose, right? So what you may or may not be seeing in the gym is either a combination or it's always going to involve your genetics. Meaning, if you don't have the genetics to be hairy in certain places, and this is the thing, guys and girls forget, men and women have hair in the same places. Women just tend to have a lot less of it in those same places. But, for many reasons, some of them cultural, guys are shaving off hair, women are shaving off hair, and it gets confusing because what we see every day is not necessarily normal. And the other thing is, grandma, if it was in her genes, and again, most women have some hair on their face. We didn't notice that there was hair on grandma's face till she was 70 because she just said, I don't care anymore. But it was probably there in her 30s. She just, would pluck one or two or whatever, maybe more, again, depending upon your genes. But testosterone itself doesn't make those genes come to the fore. They can be exacerbated, if you will, by a metabolite of testosterone, though, called dihydrotestosterone. And that's the current theory. Dihydrotestosterone can exacerbate the genes for hair in the wrong places and acne. And that's been postulated for a long time. And typically, if we control the production of dihydrotestosterone, or DHT, we can eliminate the facial hair or the hair in the wrong places. If women are using a topical, it's very difficult oftentimes to eliminate any excess hair growth entirely because it can be done locally, the conversion from testosterone to dihydrotestosterone. So where they're using a cream, if that's what they're using, oftentimes they might have a little bit more hair growth on that area where they're applying it. So I'll say, hey, well, vary the application spot, use one thigh versus the other one day and whatnot, or the abdomen. But that might be something, again, genetically dependent, but usually nothing that's not more or less manageable. And ditto for the acne. We've been using spironolactone in medicine for the longest time because while it's a diuretic, meaning it makes your body lose water and it's potassium sparing, it has a side effect of blocking the conversion of testosterone into dihydrotestosterone. It's called a 5-alpha reductase inhibition side effect, and that's the enzyme that does the converting from testosterone into dihydrotestosterone. I see a lot of athletes, and figure, I've always been the one to say, if I'm going from LA to San Francisco, I don't necessarily want to go via New York, right? Unless I got a lot of time on my hands. Instead of using something with a side effect as a 5-alpha reductase inhibitor, why not use one that's designed specifically for that, which is what men use in the form of a grand Propecia or Proscar for hair loss and prostate enlargement, respectively, or Avodart, the other brand name for dutasteride, which is even more strong, works on 3 receptors rather than 2, giving you way more information than you want. But anyway, there are ways to prevent it. First of all, it's not necessarily true that you're going to get some of these side effects. Okay, the dose is very important. The higher you go above physiologic normal, if you will, what we call the homeostatic range, and you do have to go to the high end, by the way, to get clinical benefit. We've known this since the 1950s, whether you're a male or a female. Because you're using replacement therapy, you're going to have to, your assays are going to look different than someone who's, say, in their 20s and has a healthy level of testosterone. Yours will likely be higher than that person because of the nature of replacement therapy. But the higher you go above the norm, the more your body tends to convert to some of these metabolites, one of which is dihydrotestosterone that causes the problem. We can, as I just said, pare these down so that they're within normal limits or even lower, so that you don't have the side effects, is my point. So you're not going to lose your femininity. And by the way, I have to comment on that sort of as a side note. I think I know what you mean. The outward look is what you're referring to, but feminine and masculine, I think, have a lot to do with what's on the inside too, right? So, carry yourself like you wanna, and that's the most important. But this is how you can control the outside appearance that has nothing to do with the inside. And I think she just was worried about the hair and the acne, but.
What is a daily dose, not a daily dose, but a weekly dose for some of your girls? Because I know men, we talk about normally like around 200 milligrams per week of the cypionate, correct?
Yeah, if it's in a esterified form, so a time-release form, 200 milligrams a week tends to work pretty well for most guys. And if it's a cream, 200 milligrams a day tends to work pretty well for most guys. And 1/10 of that in a cream, so 20 milligrams a day, works pretty well for females.
Well, you like injectable better than cream?
Well, for guys, yeah, because it's just what I've observed over the years. For females, because the dose is so much smaller, roughly 1/10.
Yeah.
To hold that tighter tends to be easier with cream versus, and it's not about holding it tighter. Let me back up, because it's not about treating the numbers. It's just the patients either way seem to do just as well. Female patients, whether they use a cream or an injectable.
Really? Okay.
But for guys, there's a very noticeable difference.
Okay. I didn't know that.
And part of this has to do with stuff we probably haven't identified yet, because the problem I have with creams is the titer will go up and go back down, just like it will on a weekly basis, but on a daily basis, so that the time spent with a therapeutic titer of testosterone tends to be less with creams than it is with an injectable, because it's much more easy for us to keep the titer above that minimum threshold. And for guys, it's 800 nanograms per deciliter, roughly. Since I use that because that's a number we established in the 1950s. Again, throw it away. It's just a general number for the average person, whoever that is. But the idea is that you need to keep above a certain number. And if you're doing it on a weekly basis, you're still going to have a high and a low titer, but you've got much more time above the curve, preferably the entire time above the curve, but it's because it's easier to do than on a daily basis, where sometimes you'll see people going in, they do their creams the morning before they go in to do their labs the following morning, and you'll see a titer of testosterone that's below when they even started. Yeah. And sometimes I get some psychologically, and I have to remind them, but wait, you feel fine, right? Some of them don't feel fine, though, because, again, everyone's different, and they're metabolizing the testosterone in the cream form so much more quickly that it's just harder to therapeutically keep them where they're supposed to be. But with women, I don't see as much of a difference between the two. I always try and get a sense of their personality. And again, in this country, men and women are using creams every day. But I always joke, I dropped my candy by not investing in Sephora because my wife uses so many of their creams, she's used to it. So it's easy to go, I'll just take the cream. But if you're more...
hardcore.
Well, I don't want to put it that way. But if you're into time efficiency...
Yes.
Okay, the injections work much better with men and equally as good in women, but with a lot less fuss. Because you just do it once a week.
Yeah.
Instead of every day.
So what would that be? Did you say so 20 milligrams per week?
20 milligrams per day. Oh, of the injectable. Yeah. So it equates the same. Yeah. 1/10 in the form of a cypionate.
Okay.
For females.
Oh, that's low. Okay, gotcha.
Yeah, but it works great.
Yeah,
it works great.
Very cool. All right. What's next, Dr. Rand?
Dr. Rand and Dave. I'm a 57-year-old female who has been exercising in and out of the gym my whole life. Good. Last year I was diagnosed with breast cancer. Not good. I had beaten the cancer, but in the process, that's good. Fallen out of shape, not good. And lost a lot of muscle and gained some fat. My cancer was caused by estrogen, and I found out during my treatment that I am now also low in testosterone, like I have none. I want to get back in shape and have been going to the gym every day with my husband, but no matter what I do, I can't seem to get back to where I was or even make much gains at all. And I am tired all the time. The doctors say that is normal, but I don't understand why I would still feel so tired almost a year later. They also said I couldn't take testosterone because my cancer was because of estrogen, and the testosterone would make it worse. I know you can't prescribe anything, but I was hoping you can make some suggestions to me for getting back into shape and feeling better again. Thank you for your time, Beverly. Well, this is actually a good one because if you have estrogen-sensitive cancer, that's what it sounds like she's dealing with, you definitely don't want to bring your estrogen levels up. It's just, we're erring on the side of precaution. Presumably, if the cancer is gone, unless something goes awry again, and estrogen's a normal part of any female's physiology, she should be fine. But again, we err on the side of being cautious and just say, hey, we're gonna keep estrogen at a minimum from now on, just to make sure if maybe we didn't get it all, or just because of your individual circumstances, it could come again somewhere else. Estrogen sensitive cancers can be elsewhere found in the body, not just in breast tissue. So to use testosterone, which can be converted into estrogen, is not a good idea. That's why her doctors would say that's a no-no. And a lot of people don't realize that. We get estrogen largely from the conversion of testosterone into estrogen through something called aromatase, which is mainly done, this conversion, in the liver, but also in fat cells. So you'll find, I don't know what the numbers are off the top of my head, but females who tend to carry more fat tend to have higher incidences of estrogen-sensitive cancers because they have typically more estrogen being produced. And that's, well... so we do have a great fix for this, though, because, and I know our audience is different. There's a lot that are going, who cares about an anabolic steroid? But there's a lot of women who might go, whoa, that's what bodybuilders use, and I'm going to look like a bodybuilder, and all that kind of stuff. There's an anabolic steroid, and just very quickly, testosterone molecule looks like this. An anabolic steroid is one that has taken the testosterone molecule, maybe removed a ligand, or more likely added a ligand, a piece on a particular carbon, and it makes the now slightly different testosterone molecule act differently once it enters the cell and works on the DNA of the cell. So it's not a bad thing. It's not something crazy. It's just a slight modification to what all of us naturally have. And the beauty of certain of these is that they won't convert to estrogen. So there's 3 anabolic steroids that I can think of off the top of my head that are DHT derivatives, dihydrotestosterone derivatives. So they're actually not testosterone molecules, and it's all in the name. I mean, testosterone, dihydrotestosterone, one is a metabolite of the other, and they're all very similar in structure. So I don't mean to mislead people, but they've taken a dihydrotestosterone molecule and they've changed it so that it will not convert to estrogen. Oxandrolone, stanozolol, and Primobolan is the brand. It doesn't matter because we can't get it here in the United States. It's considered contraband. But I think it's the best one because it's injectable, so it misses that first pass with the liver. But we have two here, and really for all intents and purposes, well, I shouldn't say that. My favorite is oxandrolone because with stanozolol, you have another side effect that tends to get rid of what we call angioedema, excess water, third space water that we don't want. And in certain age groups after, say, 30, you don't necessarily want that. You run some risks of drying out the body, the tendons, the ligaments. And I'm going too far afield on a side here, but I apologize. But oxandrolone, and many bodybuilders know that as Anavar, that's what it used to be branded as, is a great alternative where you get the same effects that you're looking for with TRT, where you can help with energy, libido, and fat particularly, because not only does Anavar work as an anabolic steroid to put on muscle, but studies have now bore out what bodybuilders have known for a long time, that these DHT derivatives I mentioned, and including Anavar, will not only help build muscle but help lose fat. And that's sort of the holy grail of what most people are trying to do, right? But in the case of someone who's got estrogen-sensitive breast cancer in her history, you're not out of luck because, I had the cancer, but okay, we can't ever give you anything like testosterone again, and so you're just going to live life tired and miserable and fat for the rest of your life unless you work really, really hard. And even then, I've seen it so many times. People are doing all the right stuff, but you don't have the leverage of the testosterone molecule anymore or the related molecule, and it just doesn't get done. So this is a great alternative. And in her case, Beverly, I would ask you to ask your doctor to consider it because, again, in this way, you can get the benefits without having to risk it being converted into estrogen. So this should be a good trick for you.
Awesome.
Yeah.
All right, Doc, what else we got?
This one says, "Hi there. I dropped something in my big toe about a month ago." Good going. I wouldn't have done that if I were you. And it hasn't really gotten any better. I know a hurt big toe is hard to heal because you use it so much walking, etc. I feel like I may have caused cartilage damage, maybe tendons. I'm not sure. I came to Columbia because gonadotropin is cheaper here and no script is needed. I was hoping it could help. I was wondering if instead or as well as if I might have more success shooting into my big toe or close to it. Have you ever heard of good results doing something like this? Thank you. Regards, Jody. Actually, you're laughing, but this isn't a bad idea. There are doctors, I'm thinking of one in particular, Dr. Dunn in Florida, and there are others who have injected growth hormone directly into the joint, like a knee.
Wow.
And again, it would probably be a really good idea to get this diagnosed by a doctor to find out what exactly the injury is. And a soft tissue injury, whether it involves cartilage or tendons or ligaments, growth hormone can be helpful in healing. Nice. And maybe even consider some other adjuncts like PRP or even better stem cells to help with the process. But I don't think it's a bad idea, and certainly getting it cheaper. And we can't prescribe growth hormone. We've done this before, right? Where it's illegal here in the States, except for a certain number of conditions. So it's really not a bad idea to use it, and you could inject it in the joint. The only thing is, you might want to consider not only injecting it in the joint, but systemically too, because in a joint, one of the reasons joints are so hard to heal, and the joint being everything in there, is because they live in their own little world of synovial fluid. It's a capsule, we call it, and it doesn't get much in the way of blood flow. So there's not much exchange of nutrients and cytokines, we call things that can help you heal. And so if you inject in the joint, sure, eventually there'll be that growth hormone release in the system, but no buts. For starters, growth hormone is good. It will activate what it needs to activate in the cell directly, and that should be helpful. But one of the things that is often ignored is that growth hormone will travel to the liver, and in the liver, it receives that growth hormone signal to then make IGF-1, insulin-like growth factor 1. And growth hormone gets a lot of the credit, but IGF-1 also is very anabolic and very good for soft tissue injuries. So to get the best of both worlds, you might want to consider both intra-articular injection as well as systemic injection of the growth hormone, so that so you get the best of, like I said, best of both worlds. You get some IGF-1 produced as well as the growth hormone, but it's actually not a bad idea, and it has been used before to help cartilage, meniscus, of course ligaments and tendons heal. So yeah.
Nice. Awesome.